renal pharmaceutical care. And so before she started her fellowship program, she had worked with the Ghana Health Service for 8 years. So 3 years as a pharmacist, 1 year was the acting head of the department, and another 5 years as a senior pharmacist as the Chimota District Hospital. You can put your hands together for her. And so currently, she is a clinical preceptor for residents in clinical pharmacy of both Ghana College of Pharmacists and the West African Postgraduate College of Pharmacists, attached to the Volta Regional Hospital, but now the whole teaching hospital. And so her interests are just so many, and what I have here, she has interest in infection prevention and control, quantitative and qualitative research, drug utilization studies, health economics outcomes research. Okay, I get a combination. Antibiotics resistance, medication adherence to long-term therapies, quality improvement, and the other one is mental health. And so she has won a grant. In fact, one of the biggest grants she won is enhancing hospital pharmacist roles to support the delivery of antimicrobial stewardship programs in the whole teaching hospital at the Department of Pharmaceutical Microbiology to lead this. Dear ladies and gentlemen, I introduce to you our facilitator, our chairperson for this section, Dr. Thelma Umpoku Alalbila. Yes, I have massacred the name. Yes, Thelma Umpoku Alalbila. Yes. Oh, please keep clapping. It's not easy.
Thank you very much, Divine, for that generous introduction. I'm sure we are all very full and probably a bit sleepy. We'll make this session quite snappy, but not leaving out the essentials. We'll stick to some ground rules. 15 minutes for presentation and a maximum of 3 questions. There will be informal interactions after this session. So, but we'll restrict it to 3 questions. It's 2:20 by my watch, and because we have 4 different presentations, these are the ground rules. 15 minutes for presentation, then 3 questions. Thank you. So, yes, our first presentation is by Florence Jolito and Lawrence Kofi Echampong, burnout syndrome among prison officers at Nsawo Medium Security Prison, Eastern Region.
Good afternoon, everybody. My name is DSP Dr. Florence Joleto, like our moderator has mentioned. And I'm glad we've sat through the presentations from yesterday, because you would realize that all the presentations we've had have focused mainly on the inmates, the mental health of inmates, what we are doing as a service to improve their mental health. And mind you, another question you should ask yourself is, the prison officers who are seeing to the reformation and the rehabilitation of these inmates, what state of health are they in? This morning, our chairman asked us that, are we all mentally healthy? This is just a paraphrase of the way he put the question. So we want to find out, this is what actually led to the study. Burnout syndrome among prison officers at Nsawo Medium Security Prisons. This will be the outline of the presentation. So, burnout syndrome is a state of physical and emotional tiredness as a result of chronic job-related stress. And we know that in today Ghana, there are so many stresses from the social media, from job insecurity, there's competition for work, there's a demand to give results. Just in the same way, in Ghana Prison Service too, we expect results, we expect professionalism from our officers. We are shifting from the mere inmate custody and protection. We are actually moving from that to rehabilitation and reformation. Now, this change actually puts a lot of pressure on the officers in terms of their physical, mental, and emotional well-being, and that actually results in burnout, affecting their mental health, basically. Now, the question you want to ask yourself is, most of the works on burnout that has been done in Ghana actually have focused mainly on health professionals. There's very little you see among other professional groups, and that's what actually led to this study. So the objectives, that's what led to this study, and the general objective was to assess burnout syndrome among prison officers at Nsawam Medium Security Prison. The objectives of the study were to determine the proportion of prison officers at the facility with burnout, to identify the perceived causes of burnout among the officers, to determine the association between socio-demographic factors of prison officers and burnout syndrome, and finally to find out how officers cope with burnout. This was the theory that guided our study. It was adapted from the Lazarus coping and stress and coping models, and the job demands and resources model. So it's quite self-explanatory though. So I'll just give you a second just to go through. All right. So burnout usually will manifest as emotional exhaustion, depersonalization, and loss of professional accomplishments. The job demands are the stresses we actually experience at work. Now, the job resources are supposed to be the things available to help you cope with the stress. However, there are other social factors or other factors outside of the work, like your age, your sex, marital status, or rank, which are perceived or believed to also have an effect on one's ability to work or give results. However, if you are burnt out, you realize that all these things go down to impact your ability to actually produce or give results. And you can probably find that coping strategies will help you to manage burnout. So the study was conducted at the Nsawam Medium Security Prison for obvious reasons. It's a university of all prisons. In terms of inmate population and staff strength, it has the biggest. Also, it was a descriptive cross-sectional study which involved 266 prison officers. Before you were enrolled into that study, you should have served more than 6 months, because its literature says that burnout syndrome symptoms usually will develop after 6 months of working, because you need to have worked or been exposed to stressor for a long time. So these are the variables we used for the study. And this is a table that's supposed to show the social demographic factors. There's the age, sex, rank, marital status, the years of service, basically. So at the end of the study, surprisingly enough, we found that the prison officers at Nsawam Medium Security prisons actually had a very low prevalence rate of burnout. They didn't experience the symptoms as much as we were expecting. I mean, no, not we assumed. So there was a 9% prevalence rate of burnout, and given the responses, or given the table, I don't know if you can see. Is that pointer? Is that pointer, please? Okay, so most of the respondents, the majority of the respondents were male officers. That's a 166. And if you come to the Ghanaian culture or context, you find that men are believed not to express themselves, their opinions, and they internalize their feelings. So the assumption is that this reflected in the responses. So because a lot of men actually answered the questionnaire, it's likely they might not come out openly. And this is seen in the health-seeking behaviors of men in general, right? Is it true? Okay, all right. Then the second objective was to identify the perceived causes. You would also find that the top 3 causes of burnout syndrome that officers would perceive are irregular shifts. I don't know if you can see the prints, but they are quite small. Irregular shifts, heavy workload, and loss of training opportunities. Now, literature supports that most of the causes of burnout in prison settings are usually from 4 main causes. Either from, am I talking too fast? Okay, all right. So it's either from the inmates' causes, the organizational causes, the personal or psychosocial causes, and usually from logistics. So inmates' causes, like your contact with the inmates, the aggression and all that can affect your sentence. Or logistics. So we don't have, in Ghana, that's a mantra. We don't have money to do this. We don't have logistics. We don't have weapons. We don't have everything. We have everything to keep or manage inmates. Then we have administrative causes, which usually will be, this is how things are done. You come to work at 2 o'clock, close at 8 p.m. And you know, as a regimental institution, it's yes, sir, yes, madam. I don't know if you know that, but that's how the system works. That's administrative rules. So the study revealed that officers found irregular shifts, heavy workload, and loss of training opportunities as being the main causes of burnout. It was surprising to also find out that the least perceived cause was poor social status, because you'd think that if the person is not satisfied with the work or is having issues with the work, they probably will be more burnt out. The third objective was to identify the association between the demographic factors and burnout. So I mentioned that the constructs in burnout are emotional exhaustion, depersonalization, and personal accomplishment. So from the study, we found out that the kind of shift system the service runs was significantly associated with emotional exhaustion, with about 58% of respondents running what we call the main shifts in the prison service. We have 3 different shifts. The main shift starts from 7 p.m. to 4 p.m. So that's about 9 hours shifts. Then the early starts from, that's about, actually the main shift is the longest. The rest are just about 6 hours. The next thing we found was that the officers who were in the junior ranks reported the most or had the most depersonalization symptoms. And when we say depersonalization symptoms, that's when you feel emotionally detached from your work. So when you are burnt out, you have that detachment from your work. People say nurses can just watch somebody die, and they don't really care. It's not because they don't care, but it's with time you become emotionally detached, and that's what prison officers or anybody who is burnt out usually would present with. But in the study, we found out that the junior officers usually were the ones who reported the most, and this probably could be due to the fact that they have just been recruited into the service afresh and haven't really gotten used to the system. There was no characteristic associated with the personal accomplishments in the study. A logistic regression model was used to predict that sex and dedication was associated with burnout syndrome, meaning that if you were a male officer working in some prisons in Ghana, you had a 69% reduction to burnout compared to your female counterparts. So me working in Nsawam, I'm likely to be burnt out as compared to Dr. Champo, just because I'm a female. Now, also officers with a higher degree had less reduction to burnout. So Dr. Champo, who has a higher degree, is also likely to be burnt out. Why? Because, I mean, if we bring it into our context, usually we would assume that those with a higher degree will be given a lot more responsibilities, a lot more position and all that, and it all comes with pressure. We work in a security setting, so if there's any issue in someone, who do you think the president will call first? Why? Because he's the boss. He's one sitting on the seat. I mean, he has a higher degree, qualification, and all that. He gets it. So that's what our study actually brought out. So, I mean, with all this, how do officers actually cope? Because finding out that we had a very low prevalence actually raised questions. So, is it that officers are coping well with burnout, with the symptoms, with the pressures, with the stresses? So, literature also says that people would cope with burnout either using individual strategies or use organizational strategies. When we say organizational strategies, there are some places when you go, some offices in Ghana, they have break time. They have, you have to go and leave, like you have to travel out, it's compulsory. We have a closing time where you have to, it's time.
No, 3 minutes.
I'm almost done. So like there are policies in place to ensure that staff are not burnt out. Those are the institutional strategies. But we have individual strategies where, for me, maybe I would probably take some time off, I would just rest, I would just hang out with some friends. So prison officers and someone usually will talk to their colleagues when they feel burnt out and want to cope with it. The top three are talking to their colleagues, looking forward to off duty, and reading and listening to music. Now, if you would recall, I mentioned that the main shift, which is the longest shift run by most officers, is that from about 7 a.m. to 4 p.m. thereabouts. So imagine you find yourself in the prison. When you enter the prison, it's a four-walled setting. You don't go out. I don't know if you've ever been to the prison before, but you're spending roughly 9 hours of your day inside with inmates, with other officers. Obviously, you find yourself talking to colleagues. Even if you are stressed or you are upset from home, you get to work, there'll be somebody, either an inmate or an officer, who would engage you. So I'm not surprised talking to colleagues was one of the commonest coping strategies. Looking forward to off duty. I mean, if you are running from 7 a.m. to 4 p.m. every day for like a week, we run a very hectic shift system. You'll be looking forward to your off duty. I'm not surprised they are doing that to cope with burnout. Then reading and listening to music. But you notice that if you look on top, alcohol use was the least used method. Means that our officers actually have very good coping skills and are not adopting maladaptive ways. So in conclusion, the overall prevalence of burnout among prison officers and so on was quite low. Then, despite this, female prison officers need to be paid attention to, because we need to know why being a female and so on, in a male-dominated prison or a male prison, you are likely to experience burnout. Then irregular shifts, heavy workload, and lack of regular training and opportunities for development are some of the things that prison service will have to look at to reduce burnout. Then generally, prison officers in this study adopted positive coping mechanisms. So these are the recommendations for practice for the service, for policy, and for research. Thank you.
Thank you. You did just 15 minutes. So we'll take the 3 questions. I have 1 question, 1.5, but it's not part of the 3 questions. All right. There's a hand. I don't know if you can get the microphone over to.
Okay, so thank you so much for this presentation. My name is Felicia Gato, a physician assistant student of UHAS. So My question is coming from a report that Unia TV did about Instagram prisons and how the officers, I don't know whether they're officers or, okay, let me say prison officers trade the inmates with weed and other things. I don't know if somebody also saw that report. So in your presentation, I was expecting to see something in relation of weed as pertaining to what they do to cope with, yes, cope with that, because I didn't really understand and they were showing evidences, so I believe it should be true that the inmates are they're actually using the inmates for that. So if they're actually doing that, then it means that there's a form of weed use in relation to them with the officers. So if you can enlighten me on that, and yeah, if you can enlighten me on that, whether they use that.
Thank you. Okay. Okay. Yes, please. Okay. Mine is also similar to hers, the question she asked. I wanted to find out if alcohol or drug use is, let me put it, alcohol, whether the officers are not allowed to take alcohol. Because if they are not allowed to take alcohol, it means they will not come out to tell you, okay, if I'm stressed, I take alcohol to release the stress. Similar to what she's saying, if you are an officer and you are seen using a weed or something to release stress, I think they might punish you or something. Thank you.
All right. Thank you. I'm Godfrey Amankwa, a physiotherapy student in UHAS. And I'm also doing a research on the health-related quality of life of primary caregivers of cerebral palsy children. So I also used your coping strategy by Lazarus and Folkman. So I wanted to find out, did you adapt the coping strategy to your setting, or the questions are all from the 66 items? Thank you.
Thank you very much for the opportunity. I really enjoyed your presentation. I've also read a lot about burnout in relation to job satisfaction stroke payments like salaries. But in your research, I didn't hear any bit about, even though burnout does exist, people are satisfied and they would like to go through burnout because they earn huge salaries. Someone doesn't matter about the longer shifts they would turn in if they would earn a lot. So maybe if you can talk about that briefly, because I didn't see it captured in your work. Or maybe it wasn't one of you.
So in response to your question about whether officers use, I don't know, I wasn't clear whether officers use the substance or that inmates use, which is which? I wasn't clear on that.
I think she said in relation to Onua TV, there was evidence that the officers were using inmates to get in weed into the prison. For who to use? For, you are asking who are the users?
Okay, so if they get me paid the video of what you saw on your TV, if they on TikTok, if they manage to get the substance into the yard, I'm just guessing it won't be for their use. I don't know. That's what I'm guessing. Because if you want to use it, why would you go through all the pain and trouble of getting it inside when you can use it in your comfort of your home? You get me? So I didn't say who it's meant for, but I'm just wondering why you go through all the wahala to get it inside if you are going to use it for yourself. You can just stay in your comfort of your home and just use it. Dr. Shaw.
Yes, please. I'm sure you were not here yesterday when we spoke about a research that was done on drugs. So maybe that's what informed this question. We presented something on drugs and how we tested drugs among inmates. Okay, so that's how come this morning we have to present on rap and addiction. And we made mention that about 90% of the inmates as a result of taking substances. So if they are already abusing substances outside, they find themselves in prison. Now, withdrawal symptoms sets in, okay? And withdrawals, they need it. So in every prison in the world, smuggling of substance into prisons is a big thing. You can read about it. Yes, every prison in the world, because they want to send it in. You can put all the security measures to the extent of the one you watched on Onia TV. They do something they call pumping. The person will insert it in his anus so that if you don't have scanners, you cannot be able to pick it. And the person can be able to beat security, because you cannot decide to be using your hand, or trying to find ways to see whether the thing is there, unless you have security scanners. You understand? So if you have difficulty with scanners, that means the person can go with it. When they go with it, those people who are in withdrawal, they want the substance. So they will find a way to get it. So we have to deal with it. Okay? So that's the situation. And it is something that you cannot run away from it. So what we do is to bring out the program we presented, okay, so that we can treat them. So it is a universal problem, and we are dealing with it.
Thank you, Dr. Champon. You see why I say if there's an issue, who they call? We call Dr. Champon because he has the highest. Anyways, so the second question was about the officers taking alcohol. So I'm sure some officers probably will be taking alcohol. Maybe everybody takes some amount of alcohol. Am I lying? Okay. So yeah, I get it. So in please, that was on a lighter note, so please. So it is per our regulations, you are not to drink while on duty. You understand? So if you are on duty and you are found or you are caught drinking alcohol, yeah, it's a charitable offense. You can be charged. You get it? So, but if you leave the confines of the prison and you go to your home or your barracks and you are taking your own thing, that is, so long as it doesn't interfere with your duty or as a prison officer, and you have not been caught, and there has not been any issue. They say in Ghana, laws only work when there's an issue. So there's no issue, then you thank your God. Anna? Okay. Then you wanted to know if the Lazarus, so it was adapted to my study because when you are doing research, it has to be in context. It has to be it has to be in context. So yes, so that's why, yeah. Then the last question about job satisfaction. So yes, so in my reading, in my reading and in my research, there were lots of divine. No, I'm not done. Still have the mic. Anyways, so yes, I came across a lot of literature on job satisfaction in relation to burnout. So it was one of the things I actually considered, and you will find. Please pardon me. The fonts are very small. But in the responses, there was a response about job satisfaction, and most of the officers actually reported that they took pride in their work and they were okay, they were actually okay with their work, and I'm sure that's what actually made the burnout, the rates, quite low. So it wasn't the focus, it wasn't the objective of the study, but yes. we actually touched on it. Yeah. Doctor.
Thank you so much. And please, what's your rank again?
DSP.
Right. DSP Florence Joleto. Okay. President wants to know what's the meaning of DSP.
Deputy Superintendent of Prisons.
That's a big one. Right. So just a quick one. How did you determine your sample size? Okay. And then did you compare your study with other studies, similar ones?
Okay, so I used the Taro Yemain's formula for a known population. So that's what I used. So that's what I used. Then to comparing the studies with similar one, in Ghana, there hasn't been any study on burnout among prison officers. In Africa, there was only one. That was in Kenya. Yeah, the others were in the Europes and the Americas.
Were the prevalence comparable? Or, contrast, similar, close?
They were contrasts, actually. But then one thing I came across was that in Ghana, generally, burnout rates were actually very low. Generally in Ghana. Yeah. Then in the Western world, they were quite high. Around 30 to 40% rates, yes.
Yeah. Is it applicable here?
No, because it was defined as a high emotional exhaustion, a high depersonalization, and a low professional accomplishment. But in this study, the officers were actually took pride in their job, so the professional accomplishment was on the high. Then the emotional exhaustion, yes, it wasn't, not a lot of them reported, apart from those.
Oh, Dr. Maxwell.
Okay, so maybe it's going to answer.
All right. Thank you so much, DSP Florence and your team. So I think the next set of presenters. So we have our next presenter, professional and voluntary community health workers in mental health, differing experiences in Ghana. Dr. Benedict Wirobong.
Thank you.
You
got it right.
Thank
That's okay.
you.
Yes.
And Leila Ajan Kamara.
Yes. Possibly Adam. It's a team effort, so
okay.
We'll see. So thank you very much, and good afternoon again, and good to see you after lunch. Right. So I'll be presenting, pardon me, my voice is beginning to escape me, but hopefully I'll get through this. So on the program, the title is buried a bit, so that's why if you see what she read, it's not. But it's still within the same scope of work. So the story is really about our novel approach to involving community-based or community volunteers in community mental health. So that's what I'll be sharing with you. And this novel approach is really, I'll be telling you more about it, but what we sought to do was to look at, how to engage mental health volunteers as a group, a special group, but also volunteers who are already in the health system. So we try to use both of them and to try to use that to demonstrate that we can provide community mental health. So I call this the access chasm. And I think we've heard over the yesterday and today that we are really struggling in terms of how many of us who have mental health conditions are able to access mental health care. And we did show this in some of our work we did recently when we looked at 5 districts in Ghana. And we found that less than 1% were persons with mental, neurological, and substance use disorders were able to access help. And so that is a big problem. By the way, this is me. That's when I was fair. I was attempting to be a hero. Anyways, but this is the reality. It's a stark statistic, and it's a very worrying one. The reasons why we have this issue is, I can tell you that it's down to 2 issues, 2 key barriers. Demand and, if you like, supply barriers. The demand barriers is what most of us have been talking about, and I heard some of our students telling us today already, asking about belief systems and everything. The demand barriers have to do with that. Our thinking and our definition of our belief systems around mental health are not in sync with the biomedical model. And so because of that, what that means is that people would not, if you put a hospital with psychiatrists or clinical psychologists there, they wouldn't go, because that's not what they are used to. So that is one barrier. So it's a demand barrier from you and me. We won't go and seek the help. There's also the supply barrier. That supply barrier is really what most of us probably are here, the practitioners, those who are actually there to provide the services. We don't have. And yesterday, I think we're already seeing that in Ghana, we are, even though we've made some effort, and yesterday in the roundtable, we made some comments that we have made some efforts over the years. Now we have and we have increased the fold of mental health professionals, particularly psychiatrists. But we are still struggling. If you look at the ratio of clinician to patient by population, we are still struggling. And so those are the 2 key reasons. And those reasons, if you like, particularly the demand side of it, or the supply side of it actually, could be as a result of our inability to detect. So apart from the fact that we don't even have mental health professionals, those who are there, or at least those who are at the forefront of primary health care, are not able to detect. And we did some other study, and this is what we are finding. So these charts are very, very, very frightening. What we did was, we tried to look at whether, when people routinely go through primary health care, whether they are picked as possibly having a probable mental health condition. So routine primary health care. And we did this in 3 districts in Ghana. And that is what we are seeing. Detection was almost 0. So what we did was, we planted our own people there. So after the consultation, they come out, exit interview, we assess them with our measures, we realize that they have a certain mental condition. But from the clinical notes and from the healthcare worker, they didn't pick that. Right? So that's how we determined, if you like, the detection rate. And almost all of them by condition. So we have alcohol use disorders, depression, epilepsy, psychosis. Alcohol use disorders was a bit better in Asunafo North. Maybe because that one is almost very obvious, isn't it? When someone turns up in your clinic and it's already in the thing, you would immediately know that this person has taken. So it was a bit easier. So that's what we found. Now, I'm putting these 2 there just to make a point. That if we want to turn this around, if we want to turn the access chasm around, which is a really, really one of the issues explaining that, is because we don't have the supply issues, and that even those who are there are unable to detect, then we have to begin to think innovatively. How can we innovate? How can we begin to think who can do it? Because we won't have them. It can even take 100 years. We won't have the professionals sitting at the hospitals. So begin to think innovatively. Let's take mental health to the community. And so this is where we came in, thinking about the value of, and so our approach to closing that chasm was that we will involve community-based volunteers or community health volunteers, you can call them anyhow. But what is important, that they are volunteers based in the community. So we went with 2 approaches. The first was to teach them to detect. So essentially we trained them with tools on how to screen for and pick up possible cases of mental health conditions and then refer. The other approach was to teach them how to help people help themselves. So self-help groups, like what my brother Adam was saying yesterday, self-help groups. And so we train them on how to go about that and mobilize their self-help groups so that they'll be able to take care of their mental health. So two approaches, two novel approaches. And in these two approaches, the interesting thing about these two approaches is that in this approach, where we train them to detect, we went with the Ghana Health Services volunteers. So Ghana Health Services has volunteers, okay, who do work for them. So we went for those ones and trained them. So those in the general community. But in this other approach, we went with volunteers that we're already working with. So we've been working with them, or we targeted them and trained them on mental health specific content, and they have been doing work with the self-help groups. So those are the two models we just want to highlight here, that it is possible to use volunteers either way, and it's it's clear that this is scalable because you can use the Ghana Health Services volunteers, but you can also train special volunteers to do this. So how did we do this? Or why do we think that involving volunteers is important or it's useful? First is early detection. They are within us in the community, correct? That's why they are called community volunteers. So it means they can pick early warning signs, right? Then also it helps reduce stigma. So they are going around and they are talking, and they are called community doctors or village doctors. That alone is enough. And then they're able to dispel the myths. So hopefully that helps reduce stigma. Access to care, obviously, the trained ones can then refer and get them to the people who need to see them. It's cost effective because, as you know, it's volunteerism. Even though in Ghana, I don't know if there are still altruistic people who are just volunteers by volunteers, but we still have them, and once in a while we give them a little stipend, particularly in basic needs. And so if you look at it, it's cost effective. They are not high maintenance, like some people say in other parlance. And so you can involve them, put in little resources about training, and they should be good. And then also community empowerment. You are making them own their own mental health and their approaches to mental health in the community. And so that is the rationale why volunteers, if you're not convinced, hopefully, at least these 5 reasons should give you one reason why you should invest, probably leaving or going back from here, you should be thinking about how to involve volunteers in mental health delivery. So how did we do it? We trained them to identify probable cases of mental health conditions. So we had our measures, most of them validated, particularly some of the work I've already done. So we use the PHQ-9 and the audit, alcohol use disorders questionnaire, and some other epilepsy tools, and we trained them on how to detect. We also trained them on how to refer, so how to do referrals. So we made them, it was very clear, because of the sake of this discussion, I couldn't go into detail, but they had a very strict protocol. They cannot assume to diagnose people. They're not supposed to do that. So we train them very, very carefully. If you think you pick someone who you suspect has a mental health condition, then you refer. So you call the nurse, so Mauli and his colleagues, they will call them up. What we also trained them to do, particularly in the self-help groups, was to mobilize. So the mobilization bit, but also to be able to provide a warm and supportive contact in the self-help groups so that they know that they belong, and encourage them to be able to continue fighting. And obviously clearly you can see there is a bridge between the community and the health system. These are some of the results. So we found something, and it was encouraging. So when we trained them, this was, it can remind me how many months, it varies by district, depending on when we trained each of the districts. But this would have been about 2-3 months afterwards, correct? In each district, that we began to see some of these happening. So you can see clearly that the CBSVs were able to detect, started picking up cases, and able to refer. So it was really very good. In terms of our community approach, which Adam, do you want to come and speak to that, or do you want me to just continue? Are you sure? I may not do justice to it. But anyway, in terms of our community approach, what has happened is our community volunteers have been able to reach a staggering almost 17,000 people within the communities within a period of what? 1 year. I mean, this is phenomenal, and that is the kind of thing that we thinking outside. I like President's use of thinking outside the square. and not outside the box. We're all used to saying outside the box, but thinking outside the square kind of approach is where we can use community resources, and this is the level of impact. And they're able to mobilize, and the mobilization efforts are amazing. I mean, he said that yesterday, so I don't need to go over that again today, but those who were here yesterday, you saw what he said about the self-help groups in terms of how they're able to mobilize, and then obviously to refer. So what does this all mean? What it means is that volunteers, community volunteers, can be key players in mental health care delivery in our system, particularly here. And I like one of my colleague doctors who was here, that we should begin to look at developing our own models and our approaches to doing things. And that is a clear example of that we can do that. And the whole thing about tax shifting, if you know about tax shifting, this is really falls within that realm, that we can begin to offload some of these tasks that Mauli would have to be doing. Mauli doesn't have the resources to be going to the community every week to do sensitization and whatever. But if we had our volunteers sitting there, hopefully Mauli doesn't need to go, and then it saves us cost. So that is the kind of thing. And they provide crucial support to mental health workers by conducting home visits, and you saw from what I showed you, that leads to very, very good recovery rates, because like Adam was saying, it's sometimes even the language. Most of them, they don't even understand certain things, and you have to use the volunteers are really the conduit where you can use to reach the self-help group participants or beneficiaries to even send across a message or something. And the other thing is, in fact, during the COVID period, we saw them that they were very useful in terms of how they helped us to reach people during COVID. They can do these other things in terms of training. What we learned from this is that our training needs to be innovative. You cannot do community volunteer training just like we would do here. If I were doing a lecture to my students, I couldn't use those approaches. You have to use some other approaches that they would understand. So Adam will tell you the kind of things they were using with them to explain certain concepts, to break things down. Almost
3 minutes.
3 minutes. Yes, I'm almost that. So yes, we realized that being innovative in our training was also very important, and we can share some of those with you. And very, very importantly, supervision. Don't leave them alone. Don't leave them after you've trained them and empowered them. You need to continue being with them and encouraging them, because that is really what makes them excited, and they get some real fulfillment by doing this job. So that's something to take. Oh, well, that's the last slide. Thank you very much. I hope I've been able to do it within 15 minutes. Thank you.
Oh, yes. Within 15 minutes. You have some 2 minutes.
Okay.
So, you take right.
Wow. I'm so excited. I'm so excited because one of the things that we'll be talking about later on is about volunteerism. I have been actually rubbishing Ghana about it, that we don't know how to volunteer. And that's very, very sad, because through volunteerism, we gain a whole lot. As a Rotarian, in Ghana, it's a privilege, and it's become an elitist group. So please research about Rotary or Rotaract in the university and see some of the benefits of that as well. But my question for you, Doc, is how did you go about recruiting people to come into the sphere? And you use the word mobilization. So please give us more on that. Thank you.
Please, let's take more questions.
Thank you very much, Ben, for this wonderful presentation. I'm so excited it relates to community-based volunteers. But I always have an issue relating to that. That issue of volunteerism. Is it real volunteerism? Now, mental health says we should use community volunteers. NCD says we should use community volunteers. This says we should use community volunteers, and we say they are volunteering. Is it realistic? Why don't we see their importance, co-opt them into the system, and give them something, and they'll be motivated? Instead of the word volunteers, then anybody comes, I do this, I do that. I think that is the debate now. Yeah. They are very helpful. The concept of CHIPS involves volunteers. That is the basic concept of CHIPS. So if you know that they are very important, do something and forget that word volunteerism. You know, that is just my contribution to that. Thank you.
My name is Lily. I'm a UHA student reading physician assistant. So I would like to know, with this community-based volunteerism, is there any in our universities? Because we know the university is also a community. And we being clinicians, we are learning about mental health, we learn psychology, and we learn psychiatry as different courses. So is this in our university? If it's not, I think it can be considered, because we are also clinicians. And I want to ask, what is the criteria for the selection of a community-based volunteer? Because I would really want to know and see if I'm a potential volunteer. So thank you.
So I'll talk about how we recruit, or how the volunteers we work with were recruited. We all know the stigma associated with mental health conditions, and the mere fact that in the community you have been able to mobilize people with mental health conditions, and in our case people with epilepsy, to into a distinct group, you know, more or less gives or creates a certain picture about them. So people passing by who don't understand what you are doing will associate them or refer to them as a group of madmen and mad women who are sitting down. So it takes people of courage, it takes people with passion, and people with a desire to see the lives of people with mental health conditions in their communities change. As a matter of fact, people who are also willing to champion the fight for the rights of persons with mental health conditions, who, first of all, will willingly put themselves up. They will contact you to say, yes, I have seen you are holding a meeting with these people. I'll be happy to support them in any way I can if I get the opportunity. That is one. Another way we recruited was by the community leaders, because before we begin an active intervention in a community, we go through the community leaders. So sometimes the chief and community leaders will identify someone they trust and then say that, okay, we have appointed this person to work with you as far as these people are concerned. So anything you have to do with them. So once they agree, then as part of building their capacity to work with the groups, they are given some basic training to be able to work with them. Then thirdly, the group members themselves, after they have come together and they are established, they have their own leadership, sometimes they themselves identify, either within themselves or within the community, individuals or an individual they think they'll be comfortable to work with. So, and there are also people with mental health conditions or their caregivers themselves who have gone beyond just being ordinary members to say that we will take the task of ensuring our members get information, they come for meeting, they attend scheduled mental health reviews. If there is any program
if there's going to be an interface meeting, there will be those to go around and tell their members that today we are meeting with this district assembly and we want X number of men or women from within the group. So that is how we recruit our volunteers. We don't impose the volunteers on the groups. The groups and the community must first of all agree that they trust this person, the person has the passion and commitment to work with the group. Then, yes, on the issue of volunteerism, it is not entirely free, but if you look at the sacrifice they make, some of them in what they do, sometimes when they go for home visits and they try to inquire about the health, the social interactions and relationship with the family and community, compliance with medication for those who are on medication, where they realize that the person is not taking his or her medicine or the person is relapsing. So they immediately call the mental health nurse. So all our volunteers have the contact numbers of the mental health nurses within their communities. Secondly, when somebody has relapsed, and sometimes families are not in a position to take them for treatment, it is the volunteers. Some will actually put them on their motorbikes, and take them to the nearest health facility for treatment. So if at the end of the month you support the person, let's even say with a token of 200 Ghana cedis, for me, I think it is far less as compared to the effort they make. You can imagine if within a year they have visited 16,000 plus people, and that is just directly contacting them in their homes. And then to also provide somebody with Wellington boots once in 2 years, to give the person backpack, it motivates them, it gives them that recognition that yes, the person may be illiterate, the person may be unemployed, but the fact that they are associated with serving and supporting the groups and then being recognized as such, serves to motivate them. So the token of 150 cedis or 200 cedis for us does not even match up to be qualified as allowance. Some of them, their motorbikes, their tires get worn out, they get flat tires, and they use their own pocket money to do it. So I still see that as pure volunteerism. Well, maybe Ben will answer the other bit of it, but I will want to say that as far as the use of technology with our volunteers is concerned, we have not gotten there yet. And I want to tell that majority of the volunteers we work with are some who have not had any basic classroom education. So sometimes the challenge we have, which we have acknowledged, is even when you are providing a training, you will need to speak in the dialect of the people, for them to understand. So there are a few, in fact, in some cases, we have a nurse, we have a teacher, or somebody who is literate. But even when it comes to mobile phones, most of them have what we still call YAM. That will not be able to do the sort of thing that the technology may allow them to do. And then I hope that I maybe partially or wholly answered the question about our sister who wanted to find out whether she qualified to be a volunteer, but Ben will add to that.
No, and these are very brilliant ideas, and it's good that you're already thinking like this. So yes, technology is limitless. We need to begin to explore that also. And so that could be something you can begin to think about, peer-led models, but we have to start from somewhere. And then, if in a way, it's actually peer, because you can say they are community peers, and so they are able to actually connect better. I think she asked a question about community and using the university as a community, and you're absolutely right. I think anytime we talk about this, our minds go to community as in where we live in our traditional settings and, the local areas, the villages, and so yes. I think that borders on school mental health, and you are more than welcome to discuss potentials. That's another area, some new area that colleagues and I are thinking about going, and you can do that. So you can actually use peers, and so your suggestion of using peers is actually something that can be used in school-based mental health, where you can actually train peers to provide support for fellow peers in schools, particularly in university. I'm doing some work in Avrongo where we are thinking, but we are still not sure whether we can use peers and that model. But it is something that has been used all elsewhere and is found to be effective. So thank you very much. Oh, and we still have materials from the Ghana Somubi products, lots of products. Please grab one and go. Pick one for someone and spread the word. Thank you.
Madam Chairperson, give me permission to talk.
Doc, please, you have permission. You have 5 minutes.
5 minutes?
Yes.
Please add 2.
6. 6.
All right, I'll take 6. Thank you very much. Did I hear A? Why A? Because A. Okay, that's all right. That's all right. So officially, let me tell you my name. My name is Dr. Yao Amankwa Arthur. I work with the Mental Health Authority as Deputy Director, Health Promotion. But today, and since yesterday, I am here with the Mental Health and Wellbeing Foundation as a volunteer. As a volunteer, Mental Health and Wellbeing Foundation, all the members are volunteers. It's a non-profit organization. So talking about volunteer, then I said, then let me talk my matter now. So yes, you'll find in the books that I'm the project lead and the treasurer. I don't get paid. It's all volunteer. And you need, at this point, to inculcate the spirit of volunteerism into you. You should learn to do that. You have it on your CV. If I see your CV and I see that you volunteer for an organization, it gives you a plus. Any recruiter sees that, it gives you a plus. And it's an organization that we allow the young to take charge, to grow, to develop them. That is why you find Divine Kpoho as the president and me down there, Inobizo, as project lead, because we let them grow. And we are going to make an appeal to you at this moment. I think I have about 4 minutes now. Divine, come and make a short appeal to them to be part of Mental Health and Wellbeing Foundation.
That's part of our communication. So
Yes, so it is coming. Okay, in that case, this is a warm-up. Just to prepare you that the warm-up is coming. I want to see most of you as part of this organization as volunteers. Trust me, it is not something you are going to regret being part. Many of you have seen me since Tuesday, Wednesday, Thursday. I'll be here tomorrow. And you have no idea how refreshing and how it feels good to do things like this. Wellbeing Foundation has brought this conference so that we can impact knowledge, share ideas and all that. It is satisfying. It's not always giving out money, even though we are spending money to do this, you understand? But sometimes we want to see the impact that you've made. So start preparing your mind to be part of this organization. The president will issue a communique, and after that we'll talk about the rest. Thank you very much. So I have 3 more minutes.
2.
Okay, so I'll take it later on. Thank you very much.
Right. So our next presenter, Laila Adwan Kamara.
Hi, good afternoon. Oh no, I mean everyone's a little sleepy and full after lunch. Good afternoon. All right, I'm going to talk on the really exciting topic of psychotropic drug supply. And we know that there is a serious problem in this area. Is that right? Yes, absolutely. So I'm probably not going to tell you too much that's new. But we thought that it would be really helpful to just come and talk a little bit about the work that we've done in this area and to sum up some of the sort of key issues that we've identified with psychotropic drug supply. And just to give you a sneak preview, it is not all about money. And I think I said something similar on the panel yesterday. And I think the main thing to mention is that this work was done in partnership really under the leadership of the Mental Health Authority, and the chief pharmacist, Fidelisha Bakubi, should have been here to present. She's deputized me to present in her place. She's supporting with some training, a very important training that the Mental Health Authority are delivering. And the work was also done with the support of a professor, Leslie Robertson, from South Africa. All right, I'm not going to spend a lot of time here. We know that mental health conditions, mental illness is a serious issue, and that if people don't receive treatment, and we've heard a range of numbers about the size of the treatment gap. This slide says 90%, but we actually heard in the previous presentation as much as 99%, depending on where you're going. That's a huge treatment gap. That's basically no treatment, right? So we know that there's a huge treatment gap, and we know that psychotropic medicines have a critical role to play in addressing mental health conditions and illness and in supporting people towards becoming well. So, as I mentioned, we worked really closely with the Mental Health Authority on this piece of work. We really partnered together on 4 key issues with them, and psychotropic drug supply was one of those 4 key issues. And we've been working on this since 2020. We originally started the work thinking that we were going to look at whether there were any arising supply issues during COVID. So we started the program, and almost immediately COVID started as well. But we realized very quickly that a lot of the issues we were uncovering were not COVID specific, that there were entrenched and substantive issues with the supply of psychotropic drugs. Do we remember this from yesterday? You've had 4 presentations from my team now, but just very briefly, it's a 4-year disability program with a focus on mental health. It's a consortium, 5 partners, funded by the UK government. Thank you, UK government. And this is what we did. Now, this is absolutely not academic research. So anybody who asks me about sample size or any technical questions or whether I did a costing study, I'm just going to say no. This was, let's say, it's a write-up of our practical operational approach telling you what we did, what we uncovered, and then if somebody wants to go and undertake some detailed research afterwards, we will be very happy to share all of our work with you. I mean, our initial report runs to 400 pages, so we did go in depth, but it was not ethically approved and all of that stuff. All right. So what we did in 2020, between September and December, we did an assessment through stakeholder interviews, a questionnaire-based survey, an interactive workshop, and we reviewed key national documents and situational reports. And then in phase 2, that was in December 2022, we reviewed the problems and the progress, so kind of what had the Mental Health Authority been able to implement following the first phase. And they had done some stuff. And then phase 3 was between January and May 2023, when we really examined in detail some of the medicine access issues that had arisen during the previous 2 years. And we developed some recommendations working very closely with stakeholders. There were 2 key groups of stakeholders, and these were primarily clinicians on the one hand, and then procurement people on the other hand. Okay, and this is a list of some of the key components of supply access that we explored with stakeholders. So we didn't explore every single supply issue with them. We looked at, in particular, the availability of, that's a typo, oh no, I've corrected it. Thank goodness. We looked at the availability of mental health care services, we looked at financing, we looked at the selection of medicines, we looked at procurement, and we looked at supply chain management. Now, back in 2020, that 2020 phase 1 that I talked about, here were some of the early issues that were identified. Psychotropic medicine supply is erratic. I think that's probably the kindest way that we can describe the situation, erratic. And that most psychotropic medicines were only available in the specialist psychiatric facilities, and those facilities were actually often procuring them from private wholesalers. Or getting them through donations. And then we identified that procurement and supply chain processes were slow and they were cumbersome, and that projection and forecasting was wholly inadequate, and there was a tendency really to wait until there were no medicines before initiating the next procurement cycle. So these were some of the key issues that we identified. And I said earlier that, I gave you a sneak preview, it's not all about the money. And the reason I say that is that through some of our other related work as well, we've identified that, some facilities don't even bother requesting the psychotropic medicines because they don't believe they're available. So they don't even request it. And then other things that happen are that unused and expired drugs get thrown away. So can you imagine, in a situation where everybody on the ground is telling you that they can't access psychotropic medicines, and yet simultaneously some are being thrown away, right? That is not an issue of not enough finances or not enough resource. Something else is going on. All right. So when we did our follow-up review, we then looked in more detail into some of these key issues and what was going on. So one of the issues that we saw was that obviously it's really fantastic that there's this kind of growing integration of mental health into general health care, and that there's the promotion of community-based care, and we've talked about that quite a lot over the last couple of days. But what we also see is that at a district level, there's a lack of expertise in prescribing, and there's a lack of expertise in pharmaceutical management of psychotropic medicines, and that the specialists for that are largely based at the psychiatric hospitals or the teaching hospitals. Another key thing where we've seen some improvements, but it comes with its own challenges, is that there's been a lot of training going on of non-specialist healthcare workers or healthcare providers using the WHO Mental Health Gap Action Programme, or MHGAP, it's also called as well. And that training's been delivered through our program in partnership with Mental Health Authority. It's also been delivered actually quite widely through Ghana Health Service, WHO, etc. And what's great about that is that everyone is at least delivering the same program of training. So that's a good thing. If we were all delivering different programs of training, I would be a little bit worried. I'm sure we talked yesterday about issues with coordination. So at least in that case, it's coordinated. But the problem is that you can train people all right, but then if they're unable to, there's not really an adequate supply of psychotropic medicines, there's poor access to supervision for people who've been trained, and for certain medicines, there's a limited availability of laboratory monitoring as well. And actually, this issue of supervision is one that I just want to focus on, because when we delivered our MHGAP training, we did provide a couple of follow-up sessions of supervision, and that was highly effective. What we found was that when we went for the first supervision visit, nobody had really done anything to implement their training. Right? So even though at the end of the training they do these lovely post-evaluation scores that they give on the training feedback, actually they hadn't implemented really very much. But then when we went for the second, and I think we might have done as many as 3 supervision visits, we absolutely couldn't do as many as we wanted, but certainly by the second visit they had started to implement some of that training. And so that kind of supervision model was hugely helpful. But, that then is an issue of human resourcing. Who's going to do that supervision? How does that work? Financing. Right. So we all know that mental health care isn't covered by the NHIS, by the National Health Insurance Scheme, and there's a whole body of literature which essentially tells you that it should be, that it's most effective to fund mental health care through existing health insurance schemes, right? So we know that would be the right thing to do eventually, but it isn't. And then what happens currently, the system is that the Ministry of Health gives a lump sum of money to NHIA actually, and then that has to be drawn down by the Mental Health Authority to procure drugs, all right? The problem is that the budget that the Ministry of Health provides is not really based on any kind of quantification of need at all. It is simply a lump sum of what they feel they're able to provide. So it's not based on reality, it's not based on need, it's not based on anything like that. It's simply, this is what the Mental Health Authority chooses to provide. And this is an issue. And just a little side point, one of the other issues that we found was that even where there are some drugs which, sometimes they have a dual purpose, right? So you might have medicines which can be used for mental health conditions, but they might also be used for epilepsy, or they might be used for issues like dementia. What was happening was that some of those were being charged to this very limited pot, even though they would be available under NHIS. And that was because NHIS is so slow at refunding. So there were all these drains and draws on this very limited pot of money. So what we realized was that actually this has been like a 2-3 year journey trying to get mental health, probably even longer, right? But our program has been going for 4 years, so we know that. So there's been this very complex and lengthy process trying to get mental health conditions covered under the National Health Insurance Scheme. And the current plan is it's looking like they're going to cover about 4 conditions, and they're going to cover the meds only. They're not going to cover the clinical care. So that's the current plan that's under discussion. It's all still up in the air. It's become a little bit politicized, which is a real pity. But I think the main thing that I would say, and this is what came out from all of the stakeholders as well, they felt that the really prudent course of action in the short term was to focus on being really clear about what is the need, what should be the budgetary allocation, sort out some of those supply issues, sort out some of those prescribing issues, and then this kind of plan to get mental health conditions onto the NHIS can chug along in the background, and when it's achieved, which can be any time from now to the next decade, it'll be done, right? So essentially what we were saying was, don't put all your eggs in one basket, that there are other issues to sort out in addition to getting it sorted. All right. So I'm going to be super, super quick, and I'll just point out that procurement was another massive issue. So there's a centralized procurement process, but what was happening was that because the budget allocated for psychotropics was coming really late, then procurement couldn't start until really late. And in addition, because the amount was so small, bids often were only coming from a single supplier, so there wasn't proper competition, there wasn't proper quality control, and in any case, sometimes awards were given and then the supplier couldn't deliver, whether because of price increases or just because, I don't know, maybe they just chanced their arm. So some of the strategies that the Mental Health Authority has employed to address this, and this is what they're looking at doing on a larger scale basis going forward, was they look at doing things like the bulk procurement of a single medicine, so buying enough for 2 years. So, buying something with a long enough shelf life in sufficient amounts to have economies of scale. And then they also looked at awarding contracts for a 2-year rather than a 1-year time period, and that's really to avoid some of those bureaucratic and timing issues. Right, recommendations. I'll fly through this, and then if there's any questions. Right, so some of the key recommendations were that there absolutely has to be a strengthened relationship between the Mental Health Authority, the Procurement Directorate in the Ministry of Health, the Ministry of Finance, the Ghana Health Service, and the pharmaceutical suppliers. Now that's a lot of people to bring around the table, right? But actually it's the only way that this is going to work. And the other key recommendation really on this slide was just about there has to be this proper integration of psychotropic medicines into the general health system monitoring, evaluation, forecasting and quantification tools. Because currently it sits outside that system. And that's not really very sensible. So this is the same point about integration. At a facility level, psychotropics have to be integrated into the pharmacy stock and management system. They can't be managed by mental health nurses or somebody else within that system. And that the annual budget has to be informed by proper forecasting and quantification. So in conclusion, improving access to psychotropics requires a lot of big words, right? It requires a multifaceted approach, requiring a multi-stakeholder collaborative and integrated strategy that addresses regulatory, supply chain and healthcare infrastructure. What does that mean in lay terms? It means that there's no quick fix. But it is possible. It is possible. It just requires determined, persistent, consistent effort to address these issues. And really importantly, to keep raising up the issues and the impacts of what happens to people on the ground when they can't access those medications, and to keep bringing those stories to the fore. Because if that doesn't happen, then you won't have that imperative to fix some of these issues. Thanks.
Right. Thank you, Laila. Questions?
All right, thank you. My name is Elizabeth Kofo, Public Health Nursing, Level 300, University of Health and Life Sciences. All right, so my question is that I'm much concerned about the financial aspect of these psychotropic drugs, because we all know that one of the triggers for mental illness is poverty. And then here is the case that when they have to get their medications, they have to pay for it, okay? And with this issue, some people refuse to go for their drugs and then their episode triggers. So I'm much concerned about the financial aspect of it. So if you can help them with some time, thank you.
I also have a question. Yes, please. Okay, thank you. Adomatan Ebenezer, physiotherapy student, level 400. I would like to know if those drugs are also abused by people in Ghana. Sure, thank you.
All right, thank you very much. In your presentation, you mentioned something around drugs expiring at the facilities. One thing that is also noticed is that at times these drugs get to the facility when they are almost nearing expiry. So if it comes, probably 2 months to expiry, it's not possible to push it out just within that time, and it will eventually expire. You can't give it out to the patient. So what can we do for the early delivery of this medicine so that we do not end up throwing them away? Thank you.
All right, thank you. My name is Paramount. I'm a student at School of Hawaii. So I want to ask, if funding is a problem, the Mental Health Authority, don't they have that power to sort for resources outside, let's say the little that the government gives them? And if they have the power to, how far have they gone with it?
Shall I start?
Yeah. I have a question when you're done.
No problem. All right. So I think Elizabeth was talking about the poverty link with mental health. I mean, absolutely, we've looked at that in a couple of presentations over the last couple of days. And it's absolutely true that people are having to pay out of pocket. And there's some research that's been done in Ghana which shows that people with mental health conditions are paying up to a third of their household income towards their medications, which is huge. I mean, imagine just losing a third of your income just because you're unwell and you need to get some medicines. So obviously mental health medications, mental health care is supposed to be free, right? And this is really why there's now this push to get mental health care onto the National Health Insurance Scheme, because essentially then it would be free at the point of use, right? But there are so many issues with, and this is why this process has taken a really long time, because the reality is that the National Health Insurance Scheme is overextended, right? And they're already struggling, they have their own financial issues, and we know that in terms of using that scheme, although they've made a lot of improvements in terms of doing their e-invoicing and all of that stuff, we know that there are real issues remaining with them paying back the facilities, and that causes a lot of cash flow issues. And so I don't have an answer for you except to say that yes, absolutely agree that it has a huge impact on people's health-seeking behavior and their compliance with any treatment regimes when they're having to pay for something that actually should be free. And then the second question was whether drugs are being abused in Ghana. Generally, I'm sure they are. In terms of these psychotropic drugs specifically, I don't know. I mean, given how hard they are to get, I think, you know, you probably find it easier to find street drugs than psychotropic drugs. So I can't answer that question. You can maybe hold that for somebody at the Mental Health Authority. And then the issue of drugs arriving at the facility near expiry, I mean, I completely hear the problem there, and this is all part of the wider procurement and supply chain challenges that are happening. And we also know that sometimes donated stock is part of that very same problem. So donated stock can arrive and it can be short dated. It might not even be the right kind of medication in terms of what somebody's been on, and then it's the only thing that's available. So it's really, really difficult system for people on the ground at the moment who need to get access to their medicines. So I completely hear you. I don't have any solutions except to say that if we can all sort of keep working together to try and address these really entrenched supply problems, then I think that will help. And then I think if facilities can also push back, so you know, if they're getting short-dated drugs, I think they need to be flagging that. And I think the other thing that can be done is really for everyone to push for this integration of psychotropics into the general drug supply system, because currently they sit outside it, and which means that they're being managed by people who don't have that kind of drug supply experience necessarily, right? So if they're part of the general medicine system, I think that will work much better. And then there was finally a question about whether if funding is a problem, can the Mental Health Authority get more funding from other areas? I mean, absolutely, this is something certainly that the Mental Health Authority has looked at. If you look at the Mental Health Act, which Ken talked about earlier, it has provisions in it to have a mental health fund, which could be funded by a levy. I mean, these days, levy is a bit of a dirty word. Nobody wants to be told that they have to pay yet more out of their salaries towards something. And as I was saying earlier, you know, we looked at the international literature, and it absolutely says, and in fact we've got a paper coming on it, but the literature really says that health insurance schemes are the way to go, and that things like levies are not necessarily most effective, especially not over the medium and longer term, because what happens is that eventually there'll be a little spike in terms of money to the health system generally, and then over time those budgets will reduce, and then you won't have more money overall anyway, so you're back in the same problem. So I think really the push is all about trying to get it onto national health insurance, and sure, if the Mental Health Authority can supplement through corporate donations and that kind of stuff, why not? But it is never going to be enough, and ultimately this is a responsibility of government, and we're back to that question of prioritization that we've been talking about all along.
Thank you, Laila. So mine, it's maybe a bit of a question, but maybe a comment as well. Whilst you did this access to psychotropic medicines, was there any need for some training? And if there was, like, would there be a follow-up research to provide that? I guess you talked about quantification of medicines, so you might want to look at how you retrain or train on we have something we call determining the consumption rates and stuff like that. Because there isn't full integration into primary health care, it's kind of quite difficult. So if it's just going to be stationed with the 3 major psychiatric institutions, then maybe some training on determination of their consumption rates. Albeit some of the drugs come with a late, close to expiry date and stuff, but if there's some form of training in that, it can also help reduce loss and improve access.
Yeah, absolutely. I mean, I think there has historically been an issue in terms of the Mental Health Authority not necessarily having full access to the workings of the Ministry of Health Procurement Directorate, and not necessarily knowing exactly how that process was working. So I think there was an issue there, which is definitely on its way to becoming resolved. And then I think more at a facility level, you know, I'm not convinced that we need to train more people in drugs management. I think what we need to do is integrate psychotropics with the people who already know how to do this. And that's probably the more cost-effective way of doing it. You know, there have also been a number of attempts made to really cost mental health in Ghana, and I know that the Mental Health Authority worked with WHO to use the WHO One Health tool to try and cost mental health care. They came up with some really enormous numbers which scared everybody. But it's all about whether you want to go for a Rolls-Royce approach or whether you take a step-by-step building up approach to improving mental health care.
Thank you.
Thank you.
Yeah, one more.
One more presentation.
Yeah.
For the next presentation, I'll appoint myself as the timekeeper. So, how much time do they have? 15. Okay. Hold on, please. Gentlemen, I've been asked that you have 50 minutes. Yeah? Okay. So, at every 5 minutes, I'll give you an alert with a clap.
It will be very, very short this time.
I want you to enjoy your 15 minutes. So, your time starts now.
Okay. So, we had a different title in the conference program, but it's still the same follow-up. And for me, you know, some of the things that we've discussed over the last 2 days is about how do we take care of ourselves. I did say yesterday I had to wake up during the night, 3 o'clock in the morning, to talk to my staff in Australia. But in the true sense, that's Francis. He will spend that hour. But how many hours of sleep do you personally need? Anybody can tell me? Do you get your 6 to 8 hours? So, in the true sense, I ensure that I get my minimum of 7 hours sleep. And if I don't get my 7 hours sleep, I'm Mr. Grumpy. I will be Mr. Grumpy. So, well, in Australia, as I said yesterday, we acknowledge the traditional owners of the land on which we are meeting. Of course, I'm not sure whether I'm allowed to say that we are on Ewe land, and we'll pay our respect to their elders, past, present, future, and the emerging. So we've been talking about mental health. Well, I'm changing the paradigm of what we looked at as our mental health. Really, it's our emotional state, our spiritual, our physical, and our social. How do we balance ourselves? How do we take care of all these aspects of our lives? Unfortunately, most of the time when we come to the psychiatric field, and especially the presentation that Leila has just given us, when we come to talk about medication, then our patients are refusing the medication that is going to give them well. Sometimes we look at the medication as what you say in Ghana. Actually, the medication is the devil. Is the medication the devil, or the medication is supposed to help you? What is our emotional well-being? How do we regulate our feelings? Emotionally, Professor Wally talked about his own daughter being murdered and how he felt at the time. How do we prepare ourselves for our exams? What was my experience like traveling from Aflaho to Ho in the middle of the evening? The light, the road, my emotion. My emotion, starting the program, I had to take deep breaths this morning and keep thinking, oh my God, when are we going to start? I address these things in the true sense. I started nursing in London. And if anybody knows about the real Oxford Street, our street is next to it. It's called Tottenham Court Road. It was one of the most busiest streets in London. And we were advised never, as student nurses, to wear our uniform while we are traveling on that road. Why? Because lots of accidents happen. And as a nurse, you'll be expected to assist. And if you don't know what you're doing, you can be in trouble. But the thing that reminds me up to today is that it only takes 3 minutes to die. So if somebody have a cardiac arrest and you're supposed to help that person and you are not there, what's happened? Unfortunately, you've killed that person.
5 minutes gone.
5 minutes already. But in Ghana, I'm changing your national anthem to sorry. You keep using the word sorry, but you keep doing the wrong thing. Because people come late. The other day, I told them a party which was supposed to start at 2 o'clock, 6 o'clock, I haven't eaten. And I said, if I'm going to faint, in the meantime, I'm getting my lawyer. How is our spirituality? It's not about religion. Unfortunately, we've allowed religion in Ghana to overtake our spirituality. Who am I? I am Francis Aqua. He never goes anywhere without his hat. And so I've got 101 hats. Our physical health. How do we take care of our physical health? When I was coming here, I told them, in the morning, they rang me. I said, I'm going to see my doctor. He said, are you sick? No, I'm not sick. I go to have regular checkup. I bet if I ask a lot of you in this room, you will never know my age. I'll leave that one to you. What are our social connections? So these things are there to help us to balance our life. We've looked at this in our wrap. So I'm going to pass this on to Prof. Wally to talk more about how we can do our own wrap so that we can look after ourselves. We've known what is happening in the prison system in the last 4 or 5 years, and it's a big transformation. Not only the prison officers themselves, but now it's been taken over by the prison authorities for the prisoners themselves. But each and every one of us can develop our own wrap. Thank you.
Thank you, Dr. Francis. This is my prepared presentation on wellness leadership. So, if you would like to receive it, I need to get some information from you. But I'm going to stay in alignment, and I'm going to talk a little bit about what does my wrap look like. We start with the foundation called Key Concepts of Wellness and Recovery. So hope for me, as I would ask you in Seminar 1, what does hope mean for you? Is it okay I can be interactive? What does hope mean for you?
Well, you have
how many?
6.5 minutes to do interactive. And
what does hope mean to you?
It means something that I wish to see, like something, yeah, insightful.
Insightful. Hope for me is spiritual. Hope for me is having faith. Hope for me is I don't need logic or evidence for me to hold on to my faith. There is no wrong answer. Personal responsibility. What does that mean for me in preparing my route? That means that there is no blame, shame, or guilt on pointing at other people, nor myself. I'm just being Wally when I slip. I'm a creature of habits. And I take responsibility for my actions and inactions. Education, what does that mean for me? That means if something is important for me, it's my responsibility to study, to learn. When they diagnosed me with cancer, I didn't have a PhD in cancer, but I educated myself to be in acceptance of what was present. The other one is self-advocacy. Self-advocacy for me, again, it deals with let my voice be heard. If my voice is not heard, then I feel like I don't matter. I feel like that I don't count. So in the Marine Corps, they silence you. And decades later, I was living in resentment. Because what I learned, what happened, is that I didn't matter in the Marine Corps. You could be in a relationship that you don't matter. It's all about me, 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 me. Self-advocacy is giving your voice, your authentic self-expressions. Support, what does that look like for me? What I've learned is that every winner, maybe every person that you admire can tell you they did not achieve that by themselves. Someone inspired them. Someone supported them. Someone asked, how can I support you? And that is what support looks like, and everyone deserves to have a support team. I remember talking to the high school students about 10 or 12 years ago at ATTC, and I said, and if you get a person on your support team, and that person is not fulfilling, is not committed to your dreams and to your aspirations, you are to fire them and replace them with someone who's committed to you, not your spouse, not your children, but to you. And I was surprised with the response of the young adults. That I have ownership, I can fire somebody? Yeah, you can. Because it's your life. And if people are not serving you, replace them with others who will. So those are the 5 key concepts. I'm going to end there.
You have 2 minutes more.
I have 2 minutes more.
Yeah.
I'll share a minute with my peer.
So, in conclusion, it's for us to actually think about our wellness and also our own wellness. Of course, our services, we keep looking at other people rather than ourselves. Our feelings of hopelessness, feelings of helplessness, depression. In this country, somebody dies and we keep the body for how many months before we bury the person. But it's also important because we come together and we actually say goodbye to it. So there can be good things around it. Things are about, sometimes driving, things upset us. We get that emotional roller coaster. I describe it as our Melbourne weather. Changes in our eating habits, our sleep. Sometimes people get to the stage of actually contemplating taking their own life. People getting to that stage, of course, they get to actually showing signs that they no longer want to be around. How do you determine your friends are withdrawing from society or yourself? All these things do happen. In a nutshell, how do we get what we've been talking about, drawing our own wellness toolbox? Have you got support? I think I bumped into a session when a young lady was talking about going to counseling and having her first bad experience because she was made to stand up the whole time to talk. The conclusion here is, even when you go to see the counselor, being it a priest, an elder, an uncle, give them a bit of a chance. Give them 4-5 sessions. And if you are not satisfied, ask them to refer you to the appropriate person. We thank you for listening.
In fact, a bigger one, please. A bigger one. You did well with your time. Thank you very much. They exceeded by 50 seconds. I have done my job.
Thank you, timekeeper. Right. Do we have any questions for them? 3 questions.
Yes, there's a question.
Yes. Inspirational colleagues, I just wanted to check, and because you ended with social support, and I think in the wrap there's also support as part of the domains, and then you talked about social support also just before you. Is social support always good? Is every social support always good?
I'm going to invite you to discover the answer. That's what happens in Seminar 1 and Seminar 2. We create the space. We call it a sacred space. So you can be in discovery of the answer. So before I say, what do you think? I shared in my closing comments, if there's a person on your support team and your experience of not being committed to you, you have the option to replace that person. Does anyone not understand what that means? You fire that person and replace it with another human being. So that being said, I think the gentleman said, if something is not working out for you on that social support, what do? It's what? Unsolicited. Yes, well, that's not what we're talking about. Yes, sir. So the distinction here, when we say support, you are entrusting yourself to achieve your goals and dreams with someone that you believe that believes in you. Unsolicited support could be someone want to tell me what time it is and I have my own watch. Thank you for sharing, but I don't need your, I know what time it is. Unsolicited support. Is that a distinction? Yes, sir.
Hi.
Hi.
All right, so this is actually not real question, but just to add up to whatever they've been talking about raps. My name is Sairam. I love being called Mr. Love anyway. I've had my fair experience with rap, and I've developed my own rap. And my facilitator is Dr. Prof. Wali. We were the first cohort to say. And interestingly, during COVID time, I nearly died. I was in ICU, came out, couldn't talk for 15 minutes, I nearly paralyzed. And within that space, I needed support. I didn't know who to call because I didn't know who would understand me. I couldn't talk to my wife because I couldn't tell them anything. I fell on rap to come out of it. When I came out of COVID, I experienced post-COVID blues. I'm telling you, this is where I'm in a house and then I don't know what happens. I just feel like crying. I'm so overwhelmed with whatever it is, I don't know. And I don't feel like talking to anybody. I just don't know what to do. I follow my rap. And there are times all I had to do is to sit in my car, drive to the beach, go and cry. I realized it started helping me. Cry and weep and weep and weep, and then I feel good, and then I come back home. Yeah, I'm going to talk about this crying thing again here, because it became so helpful to me. So right now as I'm talking to you, so crying for me has become a tool I developed to deal with my stresses. Now, when it's time for me to deal with it, when it's time, I feel it and I know it. I don't know how to explain, but it rises this way, and then it gets here and it gets choked. And I feel that I'm choking. Psychologically, I'm choking. So then, I at times will call a friend who knows what I want to do. I say, I want to cry. And they'll help me cry. All right. So that is just one tool. That's just one tool I developed, and I'm telling you, currently as we are sitting here, I'm going through a very serious crisis, and from that time I have been in series of crisis throughout. If I tell you right now, you won't imagine it. But the crisis I had been through, psychological crisis, rap kept me going. And I cry. It's good. It's very good. Thank you.
Thank you. Thank you so much.
All right. So, thank you for this presentation. I would like to ask, as a student. All right. I would like to ask, as a student, we go through a lot of stresses. So, how do I get access to rap as a student?
Okay, that's $1 million question. Well, we are, and yesterday you were all late. The VC who had been overseas actually drove here, and she was earlier than a lot of you. And I managed to have a personal conversation with the VC and docked here. What we are going to go is we are actually going to jump into our next session, because you've just asked the right question at the right time. And what we are hoping to do is to develop some true protocols and true linkages of how we can continue to work together. Like I said this morning, we planted a tree 10 years ago, and it's been growing. It's developed a number of branches. I keep talking about Dr. Ken. He's in the room. He's one of the branches. Sarah is one of the branches. My good friend here, Divine, is one of the branches. So we want to continue the growth. So, Mr. Chair or Madam Chair, can we jump into the next session so that the communique?
The communique.
Yep.
Absolutely.
Okay.
I just want to thank everybody for the questions asked, and I think it's been interactive. We can clap for ourselves. Thank you.
So the PowerPoint presentation, but before we do that, for me, I always break the protocols. And Dr. Yao, you have to bring your gift back. But anyway, you've got your gift, so you can take your gift. But we'll start with Dr. Thelma here. And the thing is that, I actually love the color that you got, because I personally carried this all the way from Australia for you. And look at this lovely color. But we also want you to use this thing every day that you remember your mental health, our mental health, the community mental health. So thank you for your lovely time here. I've got other people that we need to appreciate. Where is Dominica? She was supposed to be here. Okay. So we started off talking about volunteerism. And Dr. Yao, I don't know, sometimes he wakes up at 3 o'clock in the morning. I like to usually tell you what time it is in Australia so that you know when we are communicating. So it's so it's exactly 2:23 a.m. in Australia. And sometimes for me, when something comes into my brain, I act on it straight away. So I send a text message and I usually say, it's your problem if you answer it. And sometimes Dr. Yao responds to my things and I ask, why are you up at this time of the night? For me, my phone sleeps in my bathroom. So after 9 o'clock, I don't answer my phone because I want to look after my mental health. So I have a break from this horrible gadget. But in volunteerism that we've talked about, I can't remember exactly when. But like I said yesterday, we started the Mental Health and Wellbeing Foundation, or Mental Health Foundation of Ghana, and UHAS was the first place. And then we had a conference at La Palm Beach. Divine is on the phone. I'm trying to say, what year was that conference at La Beach? 2016. And UHAS, Divine, come along, please. Divine was one of the students who came, and they decided to be part of the foundation, and they actually form a chapter here in UHAS. The rest is history. All the things that we've been achieving or we've done from here is being led by Divine. But I'm also going to steal another issue here, because all the people who have been the president of the Mental Health and Wellbeing chapter of UHAS have gone on to become SRC presidents. So this is a former SRC president. Yesterday, another SRC president, Norman, Abraham Norman Norte, also was a president of the foundation and became SR. So without going, I don't know your color. You've got blue. So again, this is special. It's actually got your name printed on it. You can take the boss. Another SRC president. I hope she hasn't disappeared because I'm trying to look for her in the crowd. Vivian. She was here and she's disappeared. So she will continue to do that. Wow. Dominica. She's coming. Okay, we'll wait for her. Well, Australia and United States? Should we think about United States? Nah. Prof. Wally. Prof. Wally, your name is written on here. So, this was a gentleman who came to our first conference in 2013 at the Hall of Physicians and Surgeons in Accra. Just by accident, he heard about the conference. Well, as you can see, the rest is history. Because the transformation that is actually occurring within the prison system is all credit to Prof. Wally. Now, I can tell you the number of people who have gone on to train in RAP in Ghana is exceeding the number of us here in this room. But I have personally gone to Malaysia. Has anybody else been to Malaysia here? One or two people. We have been to Malaysia to deliver RAP in Malaysia. We were hoping to go to Australia, but it's going to happen. Prof. Wally, do you want to, let's see his color. Let's see his color. Wow.
I was looking for WHO every year when they do the Mental Health Month and Suicide Prevention Month. So I was curious to know, how is Ghana celebrating this international event? I forgot the organization I went to. Probably was a government agency, and they said, well, there is a conference going on, and it's in the Eastern region. So I got the driver, so I came unannounced, but I was in search of how do you celebrate these noble events in Ghana. So now I know, and I'm going to support Dr. Francis to continue, and then I'd like to come back in circle on putting RAP on the campus here. So as you evolve and develop, you'll be the first in Africa to have RAP at your university campus.
Well, we've had a number of people who have assisted us and gone further to do this conference. But we've also had some people who have inspired me and the support. I'm going to call, unfortunately, an older person, but don't worry, it will come. So, Dr. Ben, don't walk your way. Let's recognize Dr. Ben. Unfortunately, it doesn't have your name on it, but you are, of course, you have been there.
Anyway, thank you.
Thank you.
Appreciate it. God bless.
Yesterday, we had 3-hour session after our all-day session. And we had incredible acquisition. And we had some young ladies who were very inquisitive, but they wanted to know. Unfortunately, I've got only one cup left. My young lady who is very shy. So I had a question, and she was able to deliver. Well done. So my last cup that I carried from Australia, I think Dr. Ya already got his. I don't know what his color was. But we really, really appreciate his work, getting things done, traveling from Accra to Ho, and as he had already said, volunteering. But we had somebody else on the ground here in UHAS who put the glue together. And despite the challenges of not us having the actual grounds in the UHAS campus, she has been with us. She has organized the food, and in fact, she delivered the VC here, which we have to give her a big hand of applause. And this is Dominica. So she can pick this up when she arrives. So let's go quickly through our slide here. We want to develop a communique. Well, what is all that? Next slide. And, oh, it's going to be very, 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 oh my God, I can't even say it myself. Okay, so actually, this is actually in your book. And this is on, I didn't think we actually, okay, it's actually the inside the page of your book. Pardon me. So, like I said, when we started, we had a group of people from around the world to do something. What are we going to do? We want to provide positive attitude about mental health in Ghana. In fact, like I said, when we arrived, there were 30, when we were coming to Ghana, I brought 30 people from around the world, and we had no registration, 0 registration. Today, there are several groups that we can take the pride in saying that we had the first mental health and well-being conference of Ghana. But today, I was discussing with, I think somebody, I talked to everybody. But we have what we call the advocacy platform. And today, as we are running our conference here, there is another conference. Which one is that one? Okay, last week there was something on sexual harassment in the workplace by Professor Angie. What's your finance director's Angela Foliata. Okay, they've shortened her name here. David is always there. There's another one here. Sexual harassment in Ghanaian workplace. Is that a different time? There are different group of people on that platform. Journalists workshop by Ghana Psychological Week celebration. So now, actually, we came here on Tuesday. Tuesday night, Professor Osei retired. Was on the television. Did you know that? Oh, Monday night. So, yes, things are now happening. So we are looking at positive attitude towards mental health. Hopefully, when you leave here, nobody follows you and says you've come to the Abadanfo conference. Work with local organizations to reduce stigma associated with mental health. Collaborating with government to improve mental health. And what we talked about earlier on, funding. My ambition is for us all to take a pen and paper and write to our local MP about mental health funding. So please, take it as a challenge. I can always boast and say in Australia, we spent billions of dollars in mental health. Make recommendations regarding policy implementation and services. All this research that is being done, these are all things, even some of the challenges that we've had in the process. The work that Ken has done is being recognized. This is no secret, but we heard the Australian High Commissioner talk. I got a message from the Australian High Commissioner that the suicide line, we call it Lifeline, in Australia, was coming to Ghana. Now, I get lots and lots of queries from different sources. But basically, Lifeline International is working with a group in Ghana to bring in a proper lifeline. In fact, a couple of days on the advocacy group, somebody tried to contact the existing lifeline or existing numbers. Majority of them don't work. We need sustainable, proper resources. The first thing I did was to contact my friend here and get in contact with the CEO of the MHA so that it becomes a collaborative program, not an isolation, not a program in isolation. So hopefully we are going to get a proper lifeline. Somebody is going to call when they are feeling suicidal. Encourage and initiate mental health research. Well, it talks to itself. Improve standard of training and practice for mental health professionals. For those of us who were here yesterday, well, I could have even called it a feisty debate, but it was interesting debate, and we have to be part of it in order to make the difference. We have to talk about what is working and what is not working, and help to improve the system. Stimulate development to inform public debate and opinion about mental health issues. Here we are. The knowledge you have gained from these 2 days, you go back. And like I said, for me, I love my heart. But I go to functions, I go to Rotary clubs, and I go and steal some of the little ideas. That's voluntary club, that's what is Rotary. I became the first president from African origin in my club. I broke the rule, became the first person in that club to have 2 terms. I became an assistant governor in the Rotary Club. Facilitate exchange programs between Ghanaians and regional and international institutions. And definitely, this is our things. We've achieved more than that. Like I said, we've had over 100 Ghanaians coming to one university. Oops. Oh, Madame Dominica is here. Okay, fantastic. Next slide. This is the most interesting part of the afternoon for me. It was supposed to be bold and red. Ha ha ha. The challenge is, I'll get you to have a second to read it. Do we continue with this organization or do we stop? Do we continue with this organization or do we stop? Okay, who wants to continue? Well, the floor is now open. And we want to see how we can move forward with this organization. Sarah, Divine, Esther, and Vivian. If you are here, come forward. Vivian, you nearly lost your gift too. Madame Dominica, come over. Told me off and told me that these people are not part of the university anymore. let's learn how to apply for grants. Professor Vanessa is offering. I've thrown the challenge to UHAS. I've given it to UCC. Even start with something small and it will grow. Well, it's in red. Who will organize and run the 2025 conference? He's going to throw away his hat. The hat is going. He's not going to organize the 2025 conference. Serious. He's thrown it, the challenge. I've got a group of people here who are prepared to come in. We've been having some dialogue in the background. I've mentioned Professor Vincent's name. Winifred is in this program. She completed her PhD last year. Is that last year, Ken, or the year before? Last year. She's now the head. She's heading a research grant in Australia on drug and alcohol in her first year. She went there as an associate. She's now the head. You've heard from Professor Jennifer Pepra in the suicide prevention program. And that's the leading suicide program in Australia. In fact, the head of that department actually went and be part of the government. She was part of the Premier and Cabinet to direct what we're calling government policy and initiatives. So we have the opportunity to do things. Our conversation today is how do we go forward? So I'm going to pass on the microphone to Saram, who's been part of us for a number of years and has been shown some great initiatives. But if the foundation is not going to die today, because Francis is not going to continue running the conference, I give it to you.
Thank you very much. Please, can we clap for Francis? For Francis to have thrown his heart away is quite something. And I remember we had 2 conferences before this one. After the first one, he said he is not going to do anything in Ghana again. And he is no longer a Ghanaian. He is an Australian. I said, okay, no problem. 2 years after, he was here. And then we went to Kumasi. After that one, he said, okay, this is the last one. I ain't going to do anything in Ghana again. This conference is over if it doesn't happen again. But this year, we are in Ho. But in all those 2, he didn't say, I'm throwing off my heart. Today, he said, I've thrown off. And that is quite significant. Mental Health and Wellbeing Foundation is an international organization. And at the top is very solid and active. Like we have it very solid at the top. But down here in Ghana, we'll call the first seat. Hi. Down here in Ghana, what we call the first seat of the foundation, the grassroots is quite weak, very weak. It's all because we spoke about volunteerism, we are having difficulty to get volunteers for the grassroots. You know, in Ghana, when somebody is volunteering, that means you must give me something to make it work. So if nothing is coming, it makes it quite difficult. Today, we met. This whole thing has, if you care to know, already there is a membership, paid membership of Mental Health and Wellbeing Foundation. Paid membership. So we have some people who are paid members. Has any of you here been to Cape Coast when we had a conference? Cape Coast. Were you there? Nobody. Good. So anyone who has been to Cape Coast, that time we had people paying money to register to be members of the foundation. After that,